Hello, everyone. Thank you for watching our group's debate on the topic of the use of restraints and seclusions for people with autism and developmental disability. My name is Maria Brujan, and I am connected from Orlando, Florida, and I am the introducer for the group. As illustrator, we have Alex Richmond from Orlando, Florida, we, who will be arguing the pro side of our topic, and Megan Colfie from Peoria, Illinois, who will be arguing against our topic. Covering her part will be Alex, due to some family emergency she couldn't participate. They will be sharing some visual aids. As group researcher, we have Megan Cater from Muncie, Indiana, and she is supporting both sides. As summarizer, we have Natasha Gray from Noblesville, Indiana, and our group fielder is Caitlin Valley from Daytona Beach, Florida. Caitlin will also be concluding our debate with questions. Today, we will be discussing as a group some pros and cons on the topic of restraints and seclusions for individuals with disability. We will be discussing ethical codes and showing some visuals to support our arguments. We will also be supporting our statements with peer-reviewed articles and other primary sources such as textbooks. I will now turn my time over to Alex that has some visual aids.
To start, we would like to start with a visual that gives you a clear definition about restraints. They are the interventions restricting movements. Generally falls into three categories. Physical, which is preventing free movement by applying force to a person's body. Mechanical, which is the type of physical restraint, but introduces tools such as straps, belts, helmets, and these will restrict free movement. Chemical, which uses pharmaceutical means to control a person's behaviors, movement outside of any standard treatment. Then we also have seclusions, which is the involuntary confinement of a person in a room or an area where the person is physically prevented from leaving. And then I'll turn it over to Natasha so she can tell us about some of the articles.
Okay, the first article is by Morrison, and it is titled Restraint and Seclusion in Schools, Recommendations for California. And this article discussed things related specifically to California, but also made some points that, such as at the national level, no minimum protections have been established regarding the use of restraint and seclusion in schools, especially at the state level. California fell short in that the state did not adopt provisions of any nationally recognized standards and principles. Instead, the state dropped the provisions that had previously been in place that required schools to compile data on the number of incidences of restraint and seclusion, implemented or establish behavioral strategies that would address the underlying causes of the engagement in problematic behaviors. Nationally, the GAO, or Government Accountability Organization, acknowledged that the use of restraint and seclusion techniques in schools, both public and private, can be dangerous, traumatizing, and even can cause death. And that children who are restrained or secluded, especially when methods are used that are not safe, with more frequency are at a greater risk of harm than if those methods have been used with adults. At the state level, there are divergent laws and no federal laws which govern the use of seclusion and restraints in schools that are both public and private. And restraint and seclusion methods interfere with learning and impact a child's overall academic performance.
So although this article makes some great points, there are a few limitations with this research. One of them being that it is only a report of the California restraint information, not the entire United States. The problem is that there's no national minimum protections, like Natasha mentioned. However, Morrison and Roberts report that the majority, 90% of students that are being restrained in schools have disabilities, and this is reflected in national reports as well. So that kind of lines up. This article also reports that the number of restraints and seclusion interventions is increasing dramatically, with a 120% increase from 2005 to 2012. This indicates a need for national legislation on restraints in schools, not just state laws, because the lack of legislation leaves a gray area on what is legal and what is not. These numbers also indicate that the ethical issues regarding restraints are not soon to be over, because the number is rising as the years go on.
Okay, a second article, which is in favor of the use of restraints, was written by Sarander and a few other researchers. And it is titled "The Use of Holding, Restraints, Seclusion, and Timeout in Child and Adolescent Psychiatric Inpatient Treatment." And it's a research study that was included in the European Child and Adolescent Psychiatry Journal from the year 2002. And the main points that were argued in favor of the use of restraints are, the first was that the sensitive use of restraints may provide a response to a child's need for protection from their own impulses, and may also prevent the group contagion effect and set limits for the out of control child. Another point in favor of the use of restraints was that ASD and attachment disorders were associated with therapeutic holding. A third point was that the use of holding therapy was originally developed specifically to help children with autism. And the studies focusing on a child's responses to being restrained, and the use of restraints reports both positive and negative responses. More specifically, a feeling of safety, and that an adult showing that they care is being demonstrated to the child. That restraint offers a calming effect and a possibility to work out relationship difficulties, reduces agitation, experiences of punishment, fright, and anger. And this study also included more research from Kasdan in 1984, which found that when different restraint procedures were compared, mothers found that timeout was the most acceptable method, but children, on the other hand, preferred the use of medications to reduce problem behaviors.
So in this article by Sorander and colleagues, we get some background knowledge on why restraints may be beneficial for children, especially for individuals with autism. Therapeutic holding was originally developed to help autistic children, like Natasha mentioned. So a little bit more about this research study. They found that younger children below the age of 13 with attachment disorder and autism were associated with holding techniques. The longer the children had been in treatment, the more likely they were to have been restrained. We find that restraints overall could pose a conflict between patients' clinical needs and their legal rights. But in favor of restraints, they have been said to help children and adolescents establish internal controls, but it could be construed as abuse or punishment. However, failure to intervene to protect a child could also be a form of abuse. So that's kind of where we see it being in favor of restraints. So like Alex mentioned, this study used a lot of the different definitions of restraints. So the use of seclusion, timeout, mechanical restraints, and therapeutic holding were involved in this study. And the current study found that management techniques vary with the age and sex of the patient. So for example, mechanical constraints and seclusion were commonly used for older patients and were also associated with a very low general functioning level, whereas younger children and boys were more likely to be restrained physically or with timeout. Restrictive management strategies should only apply where there is open discussion of patient and staff interaction styles, and where these techniques can be regularly reviewed by parents, people on the integrative team with the child. A lot of people need to be involved to make sure that it's remaining ethical and no abuse is taking place. However, there were a few limitations of this study. It was used in a psychiatric facility that included individuals with other psychiatric needs other than autism spectrum disorders. Other limitations are that the article fails to acknowledge the danger in allowing restraints. They talk a lot about how restraints can help children, especially those who may be harming themselves or others, but they don't talk about limits that may need to be put into place to protect these children. So there needs to be a limit to how long a student can legally be restrained and how severe the restraints are. So that was a few limitations of the study that they didn't really touch on.
When looking at our second visual, we have the BACB Code of Ethics to share. It kind of goes into support of the article that Megan was just talking about, as well as Natasha, that punishment procedures are necessary, but they need to include reinforcement procedures for alternative behavior in the behavior change program. It also goes against the use of restraints when it says behavior analysts recommend reinforcement rather than punishment whenever possible. It's also important to note that before implementing punishment-based procedures, we need to ensure that appropriate steps have been taken to implement the reinforcement-based procedures, unless obviously the severity or dangerous of the behavior necessitates immediate use of aversive procedures. Like Megan said, if it's going to cause harm to the client or anyone else around the client. Behavior analysts also ensure that aversive procedures are accompanied by an increased level of training, supervision, and oversight. This can help to reduce the misuse of the restraints. And then Code 4.09 says least restrictive procedures. It is always appropriate to use the least restrictive procedures, and it's always recommended that they're likely to be effective for the intervention.
So now I'm going to talk a little bit more about the research both against restraint and then in favor of restraints. Some of these points have already been touched on, but I'm just going to kind of summarize everything we've talked about and add in a few other points from different research articles. In terms of against restraint, according to Peterson, there were reports of overuse and dangerous implementation in restraints and seclusion, resulting in severe injury or even death. The reason for this is that restraint is often used without appropriate behavioral treatment. So restraint is kind of seen as like a last-ditch effort to stop a client from doing something that may harm themselves or others. And because of this, the client may actually be injured themselves or even die in certain situations because the restraints were not like provided appropriately. Similarly, according to Trader et al., restraints may actually increase the problem behavior instead of decreasing it. So, for example, if a child was headbanging or something like that, and to stop them, the behavior analyst went over and like gave them a hug and kind of wrapped themselves around them, that could be reinforcing for the child. They could want that physical contact with them. So that may actually reinforce that behavior because they would be more likely to do it in the future to get that hug. So it's important to know what the restraints are doing and how they're actually implementing or impacting that client. Also, restraints can be used as a shortcut in absence of systematic and comprehensive functional assessment and support plans. So if there's not a plan in place, restraints could be used as like a last-ditch effort, like I said, because there wasn't that planning in place and there wasn't a way to replace that challenging behavior that the client was having. Restraints can lead to educational, psychological, and social damage for students and even staff administering it. This is something I saw a lot in the research, is that the staff that has to do these restraints on these children do not like doing it. It kind of makes them feel pretty low. So it can be like psychologically damaging to not only the child, but also the person that has to do that. And in certain situations, it could hurt them socially if they have to be restrained when there's other children around or in front of just like anyone that would really kind of like embarrass them. Also, it can be implemented as a treatment or intervention rather than a necessary emergency procedure. So what this means is it's kind of like put in place that you'll restrain a client if they do this, not as like a last effort, but it's already there because you're already expecting that behavior to happen. And that's not how it should be. Restraint should only be used in an emergency situation when there's literally nothing else that can be done. A few notes from Megan's portion of the presentation that I'll talk about. The majority of the administrators of restraints are untrained in doing so. There are a lot of ethical guidelines that state that like they need to be trained. Crisis management is a thing. So these trainings really need to be done so they know the proper way of holding a client or doing any type of restraint. There's limited training for intensive behavior support needs, and there's a lack of evidence to support the benefits of these procedures overall. Although it is beneficial in some circumstances when a child is about to hurt themselves or others, there's not a lot of evidence supporting that this is a good thing overall. On the other side of the coin, in favor of restraints, we have, like we talked about earlier, the fact that holding therapy was originally developed to help autistic children suggests that there is some evidence that this is actually helping these children. So that's kind of the opposite of what I just said, the lack of evidence. There is some evidence, according to Peterson et al., that said that holding therapy was actually something that helped autistic children and helped them kind of cope and get over like that initial anxiety that they may be having. It may have a calming effect or a feeling of safety. Peterson also notes that when restraint is allowed, so he says that current ethical guidelines for behavior analysts specify specific instances where restraint is acceptable, such as crisis management, like I said, for dangerous behavior, or when it is included in a comprehensive behavior support plan, and when alternatives to restraint have been attempted. So it can't just be included as part of the plan automatically. It needs to be kind of like the last resort when all other things have been tried. Legal guardians and other staff should be included to prevent abuse and to support social validity. So parents and other staff at like an agency or at a school need to be aware that restraints may be used as an emergency procedure for this specific child, and they need to be aware of who is trained on these restraints and when these restraints will have to be implemented. Worst case scenario. Now moving on to Caitlin.
Woohoo, it's my turn. Okay, so I am the fielder for the group, so I am going to start our question and answer section. And just before we get to that, Megan did touch a little bit on the lack of companies and businesses who are providing a certain training for individuals who don't particularly feel comfortable with implementing restraints. So I did want to touch on the fact that there are a few companies that we did discover when we were doing our research. They're titled PCM, which is actually developed for behavior analysts, created exactly for children with behavioral needs, which is professional crisis management training. And there's also a program titled Handle with Care. So both of these programs were developed to be a training and a supplement to those people like us, therapists, behavior analysts, who may need to protect themselves within a situation in which a client has escalated and is now kind of posing a threat to themselves and others. So those are just a few of the companies that we did find that were providing services. And I know personally we have had some of the coworkers that I work with who have been trained in PCM and Handle with Care, who are able to perform certain holds and restrictive procedures that are proven to not cause the most harm to a client. You definitely want to make sure that if you are implementing a restrictive procedure, that you're doing so in a least restrictive environment, as Alex had brought up in the Code of Ethics. So we are going to move to our first question here. Our first question is, are there any strategies or methods that can help improve training for administering restraints and or decrease the need for restraints? So I think we started to cover that just a little bit right now with the PCM and the handle with care. Those are two methods and strategies that can be helped towards improving training for administering those restrictive holds. And there was also an article that we had found by Lisak, Bears, Solano, and Sharp, which covered a parent-child interaction therapy. So this was a program that was implemented kind of like a parent training situation, that parents were able to interact with their children and learn different de-escalation techniques to teach their child so that it wouldn't escalate to the point of requiring a restraint. And most of the parents who did complete the training noted a very positive outcome, that they weren't having to implement restraints with their children at home, that they were able to use a de-escalation technique that seemed to prove more effective for the child rather than a restraint. So we kind of answered that one already right there. The use of restraints and seclusion vary from setting to setting. For example, in Indiana, mechanical restraints are not recommended to be used for people in adult services. Is it ethical to use this as a way to address behavior if it is not something that can be used across various settings? What happens if a child has a mechanical restraint in one setting, but then moves to a new setting where that type of restraint is not allowed?
So I would say it's best to use a restraint that's going to be able to be generalized across all settings. It's better for interventions to be generalized across all settings for the client's success in order to have the intervention be successful overall.
That's a good point. I don't think that implementing an intervention in one environment would be ethical to implement in another environment, because it's not going to contribute to the client's success and just going to confuse them in, you know, what environment this is appropriate and what environment it's not appropriate. So I think you made a good point to say that generalizing it is definitely the way that that should be approached. Okay. So as we had talked about a little bit earlier that I brought up in the beginning, we talked about PCM. So how would PCM assist in abiding by our ethical code?
So during our research, I found one about PCM when I was learning about it myself, was that its primary focus is on prevention before the crisis occurs, which would go in with our ethical codes of making sure that we are doing everything in our power to make sure punishment is our last resort and it's not our first resort.
And that was the 4.09 code that you had mentioned before.
Yeah. Also, I think under 4.08, it says behavior analysts ensure aversive procedures are accompanied by an increased level of training, supervision, and oversight. And I think that's exactly what PCM is aiming to do. They know that these situations might come up, and they're trying to be proactive in training and making sure that when these situations do come up, there's at least someone there that is properly trained and can do it in the least restricting way possible.
Awesome. Yeah, good points. Okay, so is this research that has been provided that we've kind of covered, is it only for the use of restraints in educational environments, or is there research that is kind of backing up the home environment, where can restraints be used in the home environment as well as the school environment?
I was thinking a lot about this question because when I was going through all the research, everything was either an educational setting, like a school, or something like a clinic or an agency. I didn't find any information about restraints at home, which I thought was kind of interesting. And I kind of wanted your guys' take on this, because I think this is just like an ethical debate. I don't know. I mean, can you control what someone does at home? And it's not like these situations that are arising at school aren't happening at home. So I wonder, like, what does happen at home? And obviously, like, the ethical guidelines are in place to make sure that, like, parents, behavior analysts, everyone is following ethics at all time. But I don't know where the line is drawn between, like, what happens at home and what happens outside of the home. I also don't know how that would work in terms of, like, a behavior plan. because you could put it on the plan as saying like only an emergency situation, but then you're granting that to happen. I mean, you're like saying if this happens, they can do this. So I kind of wanted your guys' opinion on that because I didn't really find anything in the research.
Well,
Yeah, I think.
Oh, sorry.
No, go ahead, Maria.
I think it also depends on the demand. You know, some children aren't going to have those behaviors at home because school there's a lot more demand.
Mm-hmm.
And, you know, I feel like that has a lot to do with it as well.
Yeah, definitely.
Yeah, I definitely think it has to do with the function of the behavior. If there's not the similar function of the behavior that's exhibited in a different environment, then they're most likely not going to engage in those behaviors that set them off in one environment and not another. Maybe the home environment is a really good place for them where they don't, you know, have to experience a lot of escape, you know, kind of functions or a lot of attention kind of functions. Maybe they don't need as much of that as they would in a school setting where they're trying to escape multiple demands and they're trying to compete for attention between teachers and peers. But I do, however, feel as though if you are going to implement a hold in one setting under a certain topography, then you need to do so at home as well. So that's where I think that parent training really comes in handy. In that article that we had referenced earlier, is that, you know, the parents have a means of de-escalating the behavior themselves, and then also either sharing what they're doing at home with the behavior analyst so that it's consistent across all environments, or the behavior analyst is sharing what they're doing within the facility and, you know, making sure that's being carried over at home as well.
Yeah, definitely.
Okay, so we had also mentioned that self-restraints can be beneficial to a child. So how would that kind of come into play? How would a restraint become beneficial to a child?
I think one good point of how it could be beneficial is it reduces harm to oneself and reduces putting them in a situation where they could harm someone else, which will also be beneficial to them as well.
Mm-hmm, definitely. And I think kind of like what I was talking about, how it can be calming. I feel like if maybe a child was aware of their like self-injurious behavior, they could use self-restraints to kind of calm themselves down so they wouldn't get to that level. I mean, I guess it all depends on the child and like their ability to see themselves in that way. But I think it could be very beneficial and kind of self-soothing in a way.
Yeah, because when you think about it too, to add to what you're kind of saying, Megan, is that when you have, there's a lot of kids that I'm sure a lot of people have worked with across this group that really are sensory seekers, and I think engage in that, you know, SIB behavior because they're sensory seeking. So when you think about kind of the involvement of a restraint, there's definitely a lot of sensory that's going to be applied while using a restraint. You know, whether it's restricting their arm movement from hitting themselves in the head, there's going to be a lot of pressure that's being applied. And I did read an article about that that we had mentioned in the other research that had stated a young boy was enjoying kind of the sensation of the self-restraints. And when he didn't have the self-restraint when he engaged in SIB, he didn't feel as safe and experienced more anxiety than when he was using the self-restraints. So I think that there's a lot of truth to that, Megan, that it can kind of calm them down.
I also think, to go with what you're saying, Caitlin, that it goes with our compliance codes, that replacement behaviors are offered for this. So if they are seeking that restraint and they are exhibiting problem behaviors to get the restraint, we can get them to ask for the restraint in different ways, as if asking for squeezes to get the mat or asking for it in a positive manner instead of resorting to the problem behaviors first.
Yeah, at that point, it kind of starts to turn into a self-soothe and a de-escalation technique rather than so much of a restraint.
Yeah.
Okay, so let's see. We'll kind of go through a couple more questions and then start to wrap it up here. So here was a question for both sides, kind of the for and against. What ethical principles do you feel best apply to and defend your argument?
I think do no harm is definitely one that would go for our argument in favor of against and in favor of for. You want to make sure that you're using least restrictive so that you aren't harming the client and you're thinking of the client's success and not just what's going to make your job as a behavior analyst easier. And then also you want to keep them from harming themselves and others in that manner as well.
Yeah, for sure.
Yeah, definitely.
Or even the due just and the fact that you're treating them the way you would want to be treated, even if you are trying to prevent harm from happening.
Mm-hmm. I think that also goes in with treating others with like care and compassion, because you don't want them to hurt themselves or others. So you're not only like protecting them, but you're protecting others. You're protecting yourself, either for or against. You could be protecting them from restraints, or you could be protecting them using restraints. Either way.
I think, I forgot it that fast. The one for informed consent as well.
Mm-hmm.
We say that one. Would be necessary, because you wouldn't ever want to do anything to a client or put them in a hold or a therapeutic option like seclusion without having informed them of all the contingencies or why they're being used and all those other necessary reasons as well.
Yeah, definitely. And anytime you would have to use restraint, you should also like let them know afterwards. So informed consent works both before and after, I think.
Okay, awesome. So let's choose one more question here, and then we will start to wrap it up. So let's kind of give everybody an idea of, if a restraint were to be implemented for a client, what would we need that to look like in order to remain ethical? So I think I can kind of start to answer this question by knowing what I discovered about PCM and handle with care is that all of the body movements that are taught to the staff members through PCM and handle with care are very much kind of minimally invasive arm movements that still, they're not entirely restricting the client in terms of putting them to the point where they're being injured, but they're grabbing them from body points that are kind of bringing them down to the ground safely. So I know some people might be familiar with basket holds. Those are definitely a common way that are taught through PCM to kind of bring a client down gently to the ground while restricting their arm movement so that they're not able to reach back and aggress or SIB or turn their head and kind of try to bite. Those are things that are certainly implemented through PCM that are kind of taught in a certain way to remain ethical, with that goal being in mind.
Yeah, definitely. And then I think also what we were just talking about with the consent, making sure that the parent or guardian is aware that restraints may need to be used, and anytime they are actually implemented, they need to be aware of that as well. I think that's a way to just kind of protect yourself and protect your agency, and just make sure that everyone is on the same page about when this may have to be implemented.
When we had covered that also in the class, and we had talked about that discussion board and watched the video on the boy in Florida who was actually being restrained without the parents' consent and knowledge and actually became injured that way. And now that is a major lawsuit because that was highly unethical, and they were not implementing the restraints according to the training that they had received at all. So I think it's very important, even when you do receive the training, that you're implementing it accurately and that there's someone who is readily available to kind of assist you in making sure that those trainings are being implemented the way that they're intended to be.
Our code of ethics also says that they are supervised.
Yes.
By your supervision and oversight.
Absolutely. Yeah, you need to make sure that you're being oversought rather than just implementing restraints on your own behalf. They need to definitely be part of the behavior plan.
Yeah.
And also, I feel like always keeping record of everything, like incident reports and everything like that, is very important.
Yeah, definitely a log, a restraint log. We have had those implemented within our center, that if we are implementing restraints, we need to write the duration of how long we've implemented the restraint, in addition to ABC data, what had happened before or after, and how long the restraint lasted from beginning to end.
Yeah.
Okay, so does anybody have anything else to add or wants to follow up with any more questions? Okay. So thank you guys so much for watching our debate. I hope that we answered all of your restraint and seclusion questions. And this will be the end of our debate.
Bye.
Bye.
Bye.